نحن ممكن نبدأ. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everybody, and we are delighted this evening to listen to Dr. Nancy Al Rakkad, and of course we are very honored to have Professor Ahmed Qatamish with us. Both names, Dr. Nancy and Professor Ahmed, are and Professor Tariq are international figures in the cornea field, and today or tonight Dr. Nancy will talk about the endothelial keratoplasty tips and tricks, and of course we will get benefit from the presence of Professor Tariq because he has a very long experience in Dmacc. At the same time, Dr. Nancy has a very long experience in Dmacc. So I think it will be a hot discussion, when to do this, when to do that. So we will listen and learn. Thank you very much, Dr. Nancy. The stage is yours.
Thank you very much, Dr. Mazen, and I'm honored that Dr. Tariq is joining the stage, let's say, with me. I will share my screen now. And
just a second, I think I have to give you the permission. Okay, done.
Okay. You allowed screen sharing?
Yeah.
Not yet. Not yet.
Not yet.
Mm-hmm. Here it shows that panelists can share. Maybe take some time.
Let me see.
No, not yet.
No, not yet. Just let me just open the window and see. Just give me a second.
Good.
Yes?
Yes.
Okay, so my talk today will be about endothelial keratoplasty made easy. And I'll be focusing on, we all know that endothelial keratoplasty has so many subtypes. We have the decimal stripping automated endothelial keratoplasty, the Dmacc. We have the ultra-thin Dmacc, and also we have the state-of-the-art Dmacc. As Dr. Mazen highlighted, I'll be talking about the Dmacc part, but I will be talking about the ultra-thin Dmacc, and I'll discuss shortly why I chose this to describe my experience with the endothelial keratoplasty. Now, before we start, I would like to emphasize on that endothelial keratoplasty procedures such as the Dmacc, the Dmacc, have become the preferred treatment for endothelial dysfunction and disease, as they allow selective replacement of disease endothelium. Now, the cornea transplant is all about the selective replacement, whether it's the anterior lamellar surgery in the Dmacc, or the anterior lamellar keratoplasty, or the posterior lamellar, that is in the subtypes, the Dmacc, the ultra-thin Dmacc, the nano-thin Dmacc, and the Dmacc. Now, despite all, I would like to say that Dmacc is still the procedure of choice for all types of corneal transplants, because it has a wide spread, and the learning curve is shorter than the Dmacc. I'm choosing to talk about the ultra-thin Dmacc, and why? Because it combines the best of two worlds, which is a procedure that shares the improved visual outcome and lower immunologic rejection rate of Dmacc, and the ease of preparation and surgical handling of the conventional Dmacc, while minimizing post-operative complications and few detachments. It's a simple, reproducible, and there's almost no wastage of tissue. If we want to compare, the learning curve of Dmacc is easier than the Dmacc. We need to use a microcurtam. The graft manipulation is easier. There's no wastage of tissue. It is less a waste of tissue, and graft dislocation is less. While compared to Dmacc, the speed of recovery in the Dmacc is better. The hyperopic shift in the Dmacc is less or almost negligible. There's no risk of anterior synechia. And the number of cases that attain 20/20 vision in the Dmacc is better. And this is a comparison between the conventional Dmacc and the Dmacc. Now, in the ultra-thin Dmacc, we're accommodating what the good outcome in Dmacc, but we're performing Dmacc. And that's how, if the donor tissue, this is how the idea came. If the donor tissue in Dmacc is cut thinner than in the traditional tissue, then the visual outcome is improved and almost equal to Dmacc. So we have lower rejection rate, more predictable tissue handling, fewer detachments, and lower rebubbling rates. When we talk about Dmacc, we're talking about the grafts that are almost 130 microns in thickness. In Dmacc, the graft thickness is only 14 to 20 micron, which is a true replacement of the descendant membrane. In the ultra-thin Dmacc, we're talking about then less than 100 micron in thickness, while in the nano-thin Dmacc, we're talking about less than 50 micron of corneal thickness or lamellar thickness. So who are your candidates and who are not? Actually, any patient who has a bullous keratopathy due to Fuchs dystrophy, pseudophakic bullous keratopathy, a post-failed penetrating keratoplasty, a post-tube or trap endothelial decompensation, chronic hereditary endothelial dystrophy, CHED, ICE syndrome, post-Stroma, and posterior polymorphous corneal dystrophy, all causes of disease endothelium can undergo Dmacc or ultra-thin Dmacc. It is contraindicated in stromal scarring, if there's vascularization also, if there's peripheral anterior synechiae, if there's vitreous in the AC, if you have a corneal thickness that's above 1,300 micrometer, because the thinning after the surgery is unlikely to go back to normal, and if we have a very shallow AC because of technical difficulty during surgery. Now, one trick before you attempt insertion of a Dmacc graft is to check the status of the lens. To see if the eye is phakic or aphakic or pseudophakic. What's the status of the anterior chamber, the posterior chamber, the sulcus, the sclera, and the iris. If there's any iris problem, plateau iris, adhesions, and the position of the iris. How about the pupil? Check the dilatation, check if there are any vessels on the iris, because sometimes manipulation causes bleeding in the anterior chamber. This will interfere with the quality of your graft. If there's iris atrophy, that will cause disturbances and bellowing during surgery. And also in patients, it's important sometimes, especially in a PKP, previous penetrating keratoplasty that's rejected, to obtain an anterior segment to corneal OCT to make sure that the interface is smooth, because if the interface of the cornea, the posterior interface is not smooth, as in the picture highlighted with the arrow here, this will affect the attachment and smooth attachment of the graft to the posterior lamellar, posterior corneal surface. Let's talk about the classical preparation in Dmacc. Now we are in the time of luxury that we can obtain a pre-cut Dmacc tissue that you don't have to manipulate a lot with it, and the eye banks are around the world, in the States or in Europe, they can provide you with a already pre-cut tissue. I learned it the hard way. I learned how to prepare Dmacc from Massimo Boulson himself, and so I performed this being in a tertiary center. I like to cut that freshly and use it on the spot, but sometimes I do import some pre-cut tissue. So I'm going to go over this quickly. Usually a donor corneal scleral disc is placed on an interstitial anterior chamber, and the donor corneal epithelium is removed using a PVC sponge. The height of the infusion bottle is set at 120 cm, and the roller clamp is closed 10 cm before the artificial anterior chamber to increase the chamber pressure to around 200 millimeter mercury. Pressure in the AC is also measured using a barakeratometer. The corneal thickness is measured with a pachymeter, and usually when the central donor corneal thickness between 500 and 510, an automated microkeratome, usually a 350 micron head, is used to remove the anterior lamellar cap. And this is the way it is used in eye banks to prepare a pre-cut corneal button. Now, how to cut an ultra-thin tissue? Usually the classical way of preparing ultra-thin graft consists of mounting this corneal scleral disc on an artificial anterior chamber. We clamp, control the bottle height, we measure the corneal thickness, and we choose the microkeratome head. And we have more than one way. Their heads are available in many thickness. We have the 400 micron, the 450, 350, and you go a decrease in size. And then you have the debulking heads, the 90 and 110 and 130. This is a refining step. So the first step, you use the microkeratome head to create a free flap or free cap of the anterior stroma. I usually use the 350 micron, and then I use the pachymeter to measure, and I do a second step using the 90 or 110. Or the double pass with 200 head that are in opposite direction. And this is the way that it was used by or described by Busen in 2009. Now, lately, I have been using another way of obtaining ultra-thin Dmacc grafts, which is a technique described by Romano et al. In 2017, which is the alcohol thinning technique. And so that you avoid many equipments, and sometimes the pachymetry cannot be very precise when the residual bed is very thin. So and use a one head with a single pass. It gives me less time and fewer equipment and heads are needed. So what I do is I start thinning the cornea using alcohol and sponge with 30% concentration. And I control the chamber pressure with double clamp. And I use the alcohol sponge not more than 3 to 4 minutes to avoid damage to the endothelial pump. And to avoid the wedge-shaped flap that results from the curvilinear heads, I adopted the linear microkeratome system by Moria and got reliable and more regular cutting surface. Now, this video will show how I just keep, after removing the epithelium, I use the alcohol spear and for 1 minute almost, and then I measure the thickness of the cornea using a pachymeter. Now, the alcohol's role is to dry the cornea, to thin it a little bit. If you have a freshly cut cornea, usually I don't use it for a long time. The imported corneas, because they are being in Optidol for a long time, they come with like 600 and 700 micron thick. So I use this method to thin it in order before I cut it, and I go down as low as 500 microns, which is enough for me to perform the microkeratome cut. It's important not to exceed 5 minutes all in all, because you have a high IOP, not to damage the endothelium. And then I pass slowly the 350 micrometer single head. As you see, I pass it slowly, and I use saline for 20 seconds to have a uniform cut. It's exactly like LASIK SBK or curvilinear microkeratome used for LASIK flap. The only difference is that you are happy to get a free cap. So this is how I go. I go very slowly over the head to maintain a uniform cut. And when I go slowly, it gives me a deeper cut, because if you go very fast, then you get a very superficial and thinner than expected cut. And I found that very efficient, and most of the time I did not have to do another cut after this way of slow cutting. I mark my S or F mark on the stroma side, and then I refine it into 8 or 0.25 millimeter. Okay, and this is how effective the alcohol thinning is. Usually I started with initial thickness like 550, 530, and every time post-cut thickness is less than 100 micron. And after good attachment, I give very thin lenticule. 1 month post-op, as you see, I have the thickest was 75 micron, and then I got as thin as 45 and 44 micron lenticule attached to the corneal posterior surface. So what about the procedure? Now we come to the important thing. Now, the procedure is very simple and straightforward. The learning curve is easy. As long as you have a good lenticule of corneal thickness, which is ultra thin, I score the endothelium using a reverse Sinjab hook under air bubble, using a side port that I fashioned with an MVR blade. I score it around 8.5 millimeter, and then I try to dissect the tags around to make sure that it is fully separated. And I pull the decimatorexis towards the center of the cornea to make sure that it comes out as a whole rexis. Now, this is not always a very easy and straightforward procedure, especially in cases with established bullous keratopathy, because the endothelium is friable and the decimator is friable, and it comes out in pieces. It's very important when you take it out to make sure that you got all the tags around. Then I insert my anterior chamber maintainer, and I start fashioning my side port. The side port is usually between 4 and 5 millimeter in width. That is to avoid crushing the endothelial graft while insertion. And I insert my boosting glide, whatever insertion technique you use, in the wound before to make sure that it fits, because there's no time for manipulation during surgery. Then I go to define my graft. As you see, there's the F mark on the upside down. I use my Boson punch, and this Boson punch has the advantage of having a visualization of the graft. Okay, and then I make my cut, and I load it onto the, I'm not sure why is this. Okay, so after cutting, it's ultra thin that it floats. It's an untouched technique. It floats over the BSS. So I just load it with fluid, and it floats, and I scoop it with using the Boson spatula without touching it. I just use fluid to make it float, and then I scoop it over the spatula. And sometimes I use a second instrument like a Sinjab hook or a very fine instrument, and I go from the stroma side to just tuck it onto the spatula. As you see, I try to bring it to the lip of the, so this is the reverse Sinjab hook, and this is where I use it. There was a small tag here. I use it to bring it into the lip of the boosting glide or Boson spatula. And then I use my micro forceps to pull it to the lip of the glide. And then it's very important that I make sure that the forceps comes out smoothly from the wound, from the side, before I start pulling it. Now, I always say it's very important not to leave it, because sometimes the cornea flips, sometimes things happen inadvertently. So I just keep holding it until it is inside the AC. I just make a little push of BSS or saline using the artificial anterior chamber, and then I place my air bubble inside, and I take out the AC maintainer. And then I direct my surgery towards centralizing the graft, and I secure the side ports with stitches, and I wait for it to attach. Now, there are two schools. You can fill the eye 100% to make it rock hard for 10 minutes to maintain attachment of the graft, or you can just fill the eye 100% for 40 minutes, which is a slow kind of procedure, but you make sure you don't raise the intraocular pressure very high, because you only maintain a 100% air fill. And I do adopt these two ways in order to attach the graft in place. And after that, I remove 30% of the air bubble, and I leave the eye with 70% filling. And I also use dilating drops starting 15% before the end of the procedure. I use all the dilating drops, the phenylphrin, the cyclopentolate, and the midriacyl drops to prevent pupillary block. Other ways to prevent pupillary block is to fashion a peripheral iridotomy inferiorly to prevent pupillary block to happen. But in my way, I use dilating drops, and I've never encountered any problem. Now, the graft insertion technique, we have many graft insertion techniques. They always say if you're good in phaco, then you are good in Dmacc. And there are multiple ways. You can do the forceps and boosting glide pull-through technique. There's sometimes if you don't have a very good forceps, you can use the suture pull-through. You just put a suture in the graft and pull it using a suture. There's the tan endoglide, the Boson endoglide. So it's like a roller. There's also a sheet glide or the endosaver. They're all instrumentation that can be used inside the AC to roll in the graft, or you can pull it through. Now, some pearls and tips. It's very important to remove the endothelium under air and not to use viscoelastic, because that will interfere with the attachment. Avoid trauma to the stroma, and I've seen many people, they try just to score the stroma in order. There was a saying that if you score the stroma, you allow a rough surface for the endothelial side to attach, and I don't do that, and I don't avoid it because you will end up causing some scar. It's important to make the incision size from between 4 and 5 to avoid crushing of the tissue. I place the side ports at 2 and 10 o'clock position. This means that there's a shorter distance for you to pull the lens, to pull the lenticule from the other side. As I said, hold the forceps to ensure orientation. This is a bimanual pull-through technique. A push of VSS through the maintainer. Place the air bubble once the lenticule is in the AC. Close your side ports. If you have still air bubble escaping from the side ports, you can use viscoelastic over the wound in order to make sure that you're not manipulating along the eye. Fill the AC with air under pressure, and start, as I said, dilating drops. Sometimes this has been mentioned, either for 10 minutes or 40 minutes. And in the recovery room, keep the patient for 1 hour on his back. Check the intraocular pressure is very important. I don't discharge the patient until 1 hour to make sure that the intraocular pressure is good and the airfill is sufficient. And then I discharge. It's very important for the patient to lie supine for 24 hours after the procedure. And the next day review and the patient with topical steroids, antibiotic drops. Now, the good thing about ultra-thin Dmacc is that it has a very fast visual recovery. The recovery is the same as after Dmacc, with a similar percentage of patients reaching 20/20. The hypoepic shift is minimal, and the post-operative endothelial cell count is better, according to many studies. Now, I'll have some counterattack maybe from Dr. Tamish after ultra-thin Dmacc than Dmacc. And it's the good thing that you can perform ultra-thin Dmacc on most complex eyes with superior results. And this is thank you from my team at King Hussein Medical Center. Now the stage is for the panelists. أهلا دكتور Professor Guida.
الصوت مش باين يا محمد، الصوت.
اوكي. اهلا دكتور نانسي، ازي حضرتك؟ ازي دكتور طارق؟
ازيك يا محمد، اخبارك ايه؟
اوكي.
دكتور مازن راح فين؟ سابنا ومشي ولا ايه؟
سابنا ومشي.
هو طبعا حضرتك يا دكتوره نانسي ما شاء الله طبعا محاضره رائعه، بس طبعا انا زي ما قلت لحضرتك مش عارف محمد برضو زيي ولا لا. انا يعني اما بدات اشتغل اللاميلر سيرجري كنت بدات اشتغل الاول الدالك، وبعدين لما جيت اقرر ان انا ابدا اعمل الاندوثيليال كيراتوبلاستي، يعني قعدت ابص كده حواليا ساعتها وقلت قرات الفيوتشر ان الفيوتشر رايح اكتر للدماغ، فقلت ما فيش داعي اتعلم الديزاك وبعدين ارجع اغير وبعدين اتعلم الدماغ، فاشتغلت دماغ على طول. حتى I have never done even a single case of ديزاك. فمش عارف محمد عنده نفس التجربه بتاعتي ولا انت عملت ديزاك يا محمد؟
I attended some courses for the SEC and I did about 1 or 2 cases, but I am a Mac man. It's only 1 or 2 cases, and it was aniridea, so it was not suitable for the Mac at all. But I learned the Mac and the SEC, and I bought the instruments, all the instrumentation for the SEC. But unfortunately, I didn't. Or fortunately, I didn't work the SEC at all.
Yes.
Dmacc, all of
them Dmacc.
Agree with you.
Yeah. Okay. So
I think, as Professor Dr. Nancy mentioned in her lecture, that there is no comparison whatsoever between Dmacc and Dmacc.
Yes.
But as she mentioned, that the ultra-thin Dmacc have a lot of advantages, which very near to Dmacc.
Yes, absolutely.
Yes, but in my opinion, if I have the chance to make some points, the advantage of Dmacc, in my opinion, is we can choose a younger donor. This is a very good point with Dmacc. We can take a younger donor, for example, 30 or 40 or even 20 years old. The second advantage of Dmacc is it is definitely an easier procedure than Dmacc. And the third advantage of Dmacc, in my opinion, that it can deal with the difficult situations, like, for example, advanced cases with a very hazy media in which we cannot do Dmacc, anterior chamber distortion, iris defects, glaucoma, tubes, phakics, anterior chamber IOL, vitrectomized globes. So this, I think, the place for Dmacc, if compared with Dmacc. On the other hand, Dmacc, of course, has some advantages over Dmacc. The first of all, in my opinion, is the rejection rate. The rejection rate is much, much, much lower in Dmacc than Dmacc and even ultra-thin Dmacc.
Yes.
Another important advantage of Dmacc is, of course, as Dr. Nancy mentioned, the fast recovery and 20/20 vision is possible after Dmacc, no hyperopic shift. And the wound size, also the wound size in Dmacc is almost 2.4, but in Dmacc, or even ultra-thin Dmacc is much more than this.
Yes.
And a very important point for me is I can do Dmacc in any theater, but for Dmacc, I have to have a prepared theater. I have to have the microkeratome and the artificial anterior chamber, the boozing glide. But for Dmacc, nothing exceptional. Just any ordinary operating theater, I can do it. This was very important for me because, as you know, Nancy, in Egypt, we are operating in different hospitals, not strictly in one hospital. So if we can go to one hospital very well equipped and another hospital not equipped, so this is a great advantage of Dmacc, that you can do it in any theater because you don't need any special equipment. So as I have mentioned, Dmacc, in my opinion, is for the difficult cases that Dmacc cannot do. But recently, but I don't have the experience until now, we can do the pull-through technique of Dmacc. We can use the same principles of Dmacc by pulling the Dmacc graft endothelial in. I think if I master this technique, I will not find any reason to do Dmacc.
Yes,
but
I cannot argue. I cannot come and argue at that point.
So to finish with this, my point of view is the pull-through Dmacc is another great addition for Dmacc to be done in such difficult cases, the vitrectomized globes, the iris defects, the glaucoma tubes, the aphakics and anterior chamber IOL. So this is my point of view as regard the comparison between Dmacc and Dmacc.
So yeah, can I ask a question? So if you have a patient who is aphakic or aniridic, so what do you do with them?
I will transfer it to you to do Dmacc.
Thank you very much. No, yeah, I'm serious.
For example, in aphakics, if the condition of the anterior chamber is good and the iris is enough iris, I can do iris fixated intraocular lens, posterior chamber retrofixation, and do Dmacc. But of course, I can do Dmacc in aphakia because, as you know, of course, the mechanics of unfolding in aphakia is very difficult.
Very difficult.
Yes. So this is for me the indication for Dmacc is one of these indications that you have aphakia, for example.
Yes, and the problem with the in our part of the world, let me say, the Fuchs endothelial dystrophy is not that much. Although now we're seeing a larger number, what we have is the bullous keratopathy after very complicated cases. So rare if ever that I get a bullous keratopathy because of a Fuchs or because a pseudophakic bullous keratopathy that is after a routine procedure. What refers to me, especially in a tertiary center, is the messed up eyes. So even if I think of the Dmacc, I cannot just perform it because, as you said, it's deep decompensation, very thick corneas, visualization is very difficult, distorted AC, IOL that I have to explant, and all the, the blah, blah, the hassle of it.
Yes. I agree with you, totally agree with you.
Yeah. So, Dr. Mohammed Bahjat, what do you think?
I think many of the cases you mentioned, also the Dmacc can be done. You can just
we cannot hear you very well, Professor
Voice is
Gouveia.
interrupted, Muhammad.
The ACIOL and put, but if you,
We cannot hear you well.
Let me see, I'm unmuted. But
yeah, it seems that the internet.
Like this.
Connection, I think.
The internet is interrupted.
The connection. Okay.
Mohammed,
Dr.
are you
Nancy?
still there?
Dr. Nancy.
Oh, yeah.
Until Dr. Muhammad fixes his the voice, you have some questions in the question and answers.
Can I start with asking you something?
Like this? Yeah. Can you hear me like this?
It's a little bit shaky, Dr. Muhammad. The voice is shaky.
كده كويس?
Yeah.
Yes. The internet connection is not good, but I'm now
I think
near the window.
if you turn the video off, the sound will be better. I think so. The internet will be faster.
Okay, let me try. Okay, can you hear me like this?
Yes,
yeah,
absolutely.
Better, much better.
Okay, so in my opinion, I totally agree that the SEC is much easier than the Dmacc, and it's maybe easier especially in complicated cases. But the Dmacc also can be done in cases with tubes, with ACIOL, with disorganized anterior chamber, but it needs some anterior segment reconstruction and some IOL suturing, IOL replacement. And at the end, you can still perform the Dmacc in these cases. But if you have an ACIOL and you want to keep the ACIOL, I think the only solution is the SEC. Also, analytic cases, I don't think I have any solution to do a Dmacc except doing the SEC for endothelial keratoplasty. I think the SEC is the only solution in cases with NIAD.
Do you have any experience, Muhammad, in pull-through Dmacc?
No, I didn't do it because I learned Dmacc 10 years ago, and this technique was not present. So I think this technique is designed for people who are acquainted with the SEC technique and want to shift to Dmacc and to take the advantages of Dmacc. So for me, I learned the classic Dmacc technique, and I don't have any motives to change the technique. I don't have any problems with the technique.
May you let me disagree with you, Muhammad, because I think that the pull-through Dmacc technique is not just for the people who want to shift from Dmacc to Dmacc, but it is done for the complicated cases, because if you have an anterior chamber IOL, if you have an aphakia, if you have a vitrectomized globe, if you are using the pull-through technique, you will be able to do Dmacc, not just for the people who are transferring from Dmacc to Dmacc. This is my point of view. If you allow me to
I understand. Yeah, it's correct point. Yeah, maybe it's easier because the unfolding will be easier, but still there is a chance of conversion to the classic. So you may aim for pull-through technique, but the graft flips and you have to unflip it. So this is what the people who work this technique told me, that sometimes they need to resort to the classic unfolding techniques.
Yes, exactly.
So you cannot just rely on this technique. You must learn how to do the classic Dmacc unfolding techniques also.
Exactly, yes.
Yeah.
One of the advantages also for Dmacc, I think that as you know, Nancy, that in Dmacc we always use the old donor tissue. For myself, I use donor tissue above 60 years.
Preparation, yes, it's
having the very easy in preparation as well as very easy in unfolding. But I think the great advantage for Dmacc is you can use a young donor as young as 20 to 30 years. This is a great advantage for Dmacc, I think so.
Especially if you're preparing it yourself. My question: Do you import prepared grafts for Dmacc, or you prepare all your grafts?
No, for myself, I am preparing. I have never used a pre-prepared Dmacc graft. I usually prepare it myself, and this is part of the ego of the operation.
Yes, definitely, absolutely.
But I am always preparing my Dmacc grafts, and I have certain technique which I have repeatedly doing it. So I may say that I may have about above 95% success rate of preparing Dmacc grafts. And what about you, Muhammad? Do you have ever used a pre-stripped or preloaded Dmacc grafts, or you are using the same like me?
I'm like you, but I tried the pre-stripped, the preloaded also Dmacc tissue once.
Once only.
And really, it made things easier. But still, I'm insisting for preparing my own tissues. I do not trust any eye bank or any tissues for any assistant or anybody to prepare my tissue. I prefer to prepare my own graft.
And what is the success rate of your experience? I know that.
It's more. Thank you. Yes, it's more than 95%. I seldom lose any tissue.
Yes. And what is your preferred age? You insist of preparing above 60, for example, or you may go down?
No, I go down to 50, but not less than 50. Maybe 48, 49, but not less than this. And this is, of course, make choosing the tissues very difficult. It's very difficult to get an old graft with who is phakic and high endothelial cell count. So it's very difficult to get such tissues.
Yeah, actually, what I
built the corneas, Professor Nancy from in Jordan. You have a local eye bank, or
yes, we have an eye bank that was established in 1979. We have a 50% donation rate, and 50% are imported. Now, usually, if I want to prepare a Dmacc graft, it's through a DALC, because when I operate on a patient on a DALC and I want to just strip the endothelium, I use the same setting to prepare the even if at a younger stage, because I have to utilize the tissue that I have. Sometimes it works and sometimes it doesn't. As you said, if I have a young cornea, it's very difficult to prepare a Dmacc. But this is when we utilize it, because we don't have the choice if it's a locally imported, locally donated corneal tissue. So I agree, the older, the easier it is.
That's how we started at the beginning for Muhammad, I think, and myself. We started practicing preparation when we are doing DALC to be protected. This graft for this patient,
and not feel guilty if it's
without any stress.
Yeah,
and after that, we have gained experience and we started doing preparation even for the Dmacc itself.
Absolutely. I have a question. Do you perform Dmacc on young age, on children?
I have done for myself. I have done the only indications in my experience is the Chet syndrome.
Yeah.
So I have done about 7 or 8 cases of Chet.
And how old are the children?
The youngest was about 7-8 years, and the oldest was about 14 years. As you know, always the Chet syndrome always presents late.
Yes.
Because the patient can manage.
Yes.
And the youngest I have done is about 7 to 8 years. and very strange. The results were fantastic actually, because this age group actually who need endothelial graft rather than the old group, because the risk of rejection in these young children are very high.
Absolutely.
So if we do for them Dmacc, you will have a great advantage for them. So
The
I have
lesser-
done about 7 to 8 cases, not more than this.
Yeah, I think this is a very good advantage of Dmacc, because the lesser the tissue to reject, it's
Yes.
almost negligible tissue to reject. So yeah, this works, I think.
And you have done any Dmaccs for kids or?
Actually, just 2 Dmaccs in young children that worked well. Also, yeah, for 2 sheds, they're a brother and a sister, and still working, thankfully. But no more than we don't see a lot of sheds in Jordan. Actually, I just have few children. But it occurred to me that if a younger child presented, so I usually keep them to grow up a little bit, so to minimize rejection. If I can, nurse the eye at that time.
And you do dysmatorexis for them, or just put the graft over the endothelium? Because some advice.
No, I did dysmatorexis, deep decompensated cornea. I did a dysmatorexis, and it was actually difficult because the attachment is
very strong.
Very strong. Yes, it's difficult.
That's why the school of not making dysmatorexis for these young children, because it will be difficult and irregular. So the advice just putting the graft over the old endothelium.
At one point, I was just thinking, because these 2 patients were a brother and a sister, and I had a difficulty with the girl stripping out the decimate. I thought I should just leave the decimate in with her brother, but then I just felt guilty, and I did pull it out, and it came okay. It was a little bit even easier in the brother, but yeah, one of the thoughts were to just leave it in.
And there is some surgeons also advise not to do dysmatorexis if you are doing Dmacc after PKB, because as you know, if you are doing dysmatorexis, you may damage the wound from inside. So they advise just putting the Dmacc graft over the graft endothelium.
Yes, absolutely.
Dr. Mazen.
I'm just learning, mashallah. Jazakumullah khair. So yeah, there are 2 questions if you could please answer.
So the first, it's the same attendee. If the lenticule rolled, what are tips to take it in the right way? And we're talking, I think, about Dmacc. I leave the Dmacc to Dr. Tariq. And can we do Dmacc after PKP? Now, yes, we can do Dmacc after PKP, and it is advised that in a rejected penetrating keratoplasty to try to do a Dmacc even once, twice, and thrice before attempting another redo. But one of the tips that I said in the beginning of my talk, to maintain a posterior surface for attachment that is smooth. Sometimes one of the patients that had a PK that rejected, and he had a Dmacc that also failed to attach. I revised his wound first. I opened the wound for the PKP to make it a smooth attachment, and then I performed a Dmacc on him to maintain to make sure that the lenticule attached well, because you need a smooth surface to attach on. So this is one of the tips. And as Dr. Tariq said, sometimes you don't have to pull out the decimate membrane on a failed Dmacc, in a failed PK. You can just leave it in and attach the lenticule on top of it. The other question was if it rolls. Now, this is the importance of stamping, especially if you have media that is not very clear. And most of the complicated cases of decompensated corneas are not that clear. I don't do Dmacc more than 1,300 microns, because then it will be deeply opacified or cornea. That's difficult to manage. But in a partially opaque cornea, you can still see the stamp, the S stamp or the F stamp. This helps you relocate the graft. And the other tip is that's why during the pull-through technique, which is superior to the the forceps pull through, it's superior to the suture pull through, is that you can grasp the cornea with the forceps as you pull it in. And you will not, it's very important that I don't take my hand out or my forceps out until I push some saline or BSS and make sure it opens, because sometimes if you leave it and make a push of BSS, it might roll, it might tackle, or it might roll, and then you have more manipulation. And manipulation means losing of endothelial cell count. So I just keep holding the graft in my forceps until I see it open in front of my eyes, and I make sure that the stamp is in this the orientation it's supposed to be, and then that is the time I put the air bubble underneath and I take my AC maintainer. So that's tricky situation of just pulling it through, inflating it or opening it up and pushing some BSS is the tricky situation where you can make sure that you are doing it the right way.
Okay,
there is
great.
a question for the Dmacc surgeons. Thank you for the nice lecture and beneficial discussion. We need the opinion of the panelists of the DSO. First of all, I want to explain what is DSO. DSO is Descemet stripping only, or it may be called Dmacc, descemetorexis without endothelial keratoplasty. There is a technique, a recent technique of advising just making a very small descemetorexis in the center for about 5 millimeter in the Fuchs dystrophy, in the very early stages of Fuchs dystrophy, not of course the pseudophakic patients. And unfortunately, I don't have experience in such a technique because it needs a very early cases, which I don't have in my country. But I think as I have studied in the literature, it is not a decisive technique. It sometimes works, sometimes not. It may take a few months until the cornea clears. So to be honest, I don't have a real experience of doing such technique because it needs a very special early cases, which I don't have in my practice.
Yeah, absolutely, I agree. It needs a special, as you said, early cases, and it needs a special material. It's not available here. You need to bring it in.
Yes.
Yes.
And also, as Dr. Nancy mentioned, the idea of the DSO or descemetorexis Descemet stripping only, the idea of migration of endothelial cells. They depend on taking off the diseased endothelial cells in the center and waiting for the peripheral endothelial cells to migrate to cover the gap and to start functioning. This is the idea of the operation. But I don't think that it took the great respect until now. And as I have mentioned, it is revised for the very early cases, which we may not face in our career in the Arab region, especially.
We're still working for international results, I think, to yes. Adopt or not to adopt. Yeah, it's still under studying, actually.
Here a question for you, Dr. Nancy. Can we do Dmacc phakic patients? If you have a phakic patient, can we do Dmacc?
Absolutely, absolutely. We can do Dmacc in patients who have clear lenses. Now it's important. It's usually they come with cataract. Usually, even in the early stages, it's easier to take out the lens and do a triple procedure to avoid any manipulation in the future. But even though you can do Dmacc and do a cataract in the future. Now, the problem is if you want to do a Dmacc first, make sure the cornea is attached, and you cannot do a cataract surgery or phacoemulsification before 2 or 3 months of the initial endothelial keratoplasty, because you want to make sure the graft is completely attached. But still, there is a risk of, if you introduce your phacoprobe with a very strong gush of fluid in the AC, you might dissect it open, especially if you have a Dmacc, not an ultrathin Dmacc or a Dmacc. This does not work with a Dmacc, I think. All the ultrathin Dmacc, the lenticule is very thin, so dissecting it open is rare. I'm talking about Dmacc, which is the thicker lenticule. that you face it in front of you. The other thing is the Iol Power Calculation. Dmacc causes a hyperepic shift usually, so you have to integrate this in the Iol Power Calculation once you do the surgery. So if you do the Dmacc first, you have to put this into consideration for the future if you want to do a lens surgery afterwards. And if you do a lens surgery before and you are anticipating that you will do a Dmacc afterwards, you also have to make space for a hyperepic shift that be caused by the Dmacc graft, which is less with the ultra-thin Dmacc, but still there is this possibility. Of course, with the Dmacc, this is not an option, but the question is about Dmacc, so I'm answering about it.
So Nancy, do you have a special age? If you have, for example, a patient fit for Dmacc, which has a clear lens, do you have a special age? Below it, you will go for Dmacc only, and above it, you will go for triple phaco Dmacc?
Actually not. Let me be honest. Until now, all the patients who presented me with a with a bullous keratopathy due to Fuchs, let's say, with a phakic eyes, are above 45. I never had a younger patient who did not had a clear lens, except these two children with SCHED. Of course, I wouldn't take the lens out. These are to undergo cataract maybe in the future, and not to forget that we're using steroid to avoid the rejection of the graft, so they might develop a cataract at an early stage, and we have to keep this in mind. Now, performing cataract using only the aspiration or the epinucleus, which is we don't need a phaco power, is a good option in these patients to go earlier for the cataract surgery than keep it for when it becomes harder or in the nucleus creases harder in these cases who underwent posterior lamellar keratoplasty, let's say. But no, I don't have a cutoff point. No.
My experience in Dmacc, we have the age of 50. If we have a case of Fuchs dystrophy with clear lens below 50, we advise to leave it as it is. But if we have a Fuchs dystrophy which is a clear lens but above 50, we go for triple. Because as you know, in Dmacc, we are using too much time of tamponade for a few days and even gas. And this gas has make cataract. So if the patient is above 50 years, we go for triple phaco Dmacc. But if it's still under 50 years, we can reserve the lens for a few years.
Absolutely.
Okay, great. So I think no more questions. Professor Osama Ibrahim, it's a great honor that you are with us. So if you have any participation, contribution to the discussion.
He's putting his mic off, I think so. Dr. Nancy.
Yes.
May I allow me to ask a question, Dr. Mazen?
Yes, please.
Dr. Nancy, if you have one of your fellows now is coming to you and telling you, please advise me, I want to learn endothelial keratoplasty, what do you advise? Which way to go through? To go through this?
Dmacc, go for both, of course.
Or to go through Dmacc direct.
I will not say go to Dmacc direct. You have to learn. I think it's learning the extra cap, even if you don't use it.
Yes.
And learn the phaco better, because at some time you never know. You can't just go the Dmacc without having a Dmacc as a standby. And all my fellows, they know how bad and complicated our cases are. I think the more we become a modernized countries, the screening is earlier, then we will not have these complicated cases. And more younger doctors, they perform phacos, maybe the complication rate is less, then the emerging importance and the luxury of the Dmacc will surface. And I have one of my fellows now doing Dmacc in UK. So she saw the hassle we're going through, and I'm waiting actually for her to come back and just share the ideas of maybe tips and tricks I haven't learned when I was there at that time. It's a continuous process of learning, actually.
Yes, of course, I agree.
But I don't advise just jumping over straightforward to the. It won't work in a tertiary hospital like ours, actually.
Yes, I agree with you.
But it's both are very important. I agree. I totally agree.
You give a great example of not only to learn phaco directly, but you have to learn extracapsular. You will need it at some time. Yes.
Absolutely, yes. You have all the tools with your hands. This is the best way.
Yes, exactly.
Absolutely.
Now, I have a question, please. Since, of course, I'm not expert in such operations, and because you know that I am very interested in teaching. Now, let me say, if we want to teach students who are interested in this field, of course, there must be theoretical part and then hands-on, all right? What do you think the percentage of the theoretical part? It should be like 70% important and 30% hands-on, or vice versa, because the new generation of doctors, they think that doing operations is everything without having the principles and the basics. So what do you think? Let's say if we want to make a course regarding the corneal surgeries, 70% theoretical and 30%, or 60-40, what percentage do you think?
Nancy.
Should I start? Okay. I think this is a very important question. Although it is surgery, but understanding the basics of corneal disease and tissue and how to handle it is very important, because you might do this procedure straightforward, but you cannot explain what's going on if you don't have the basics. So I say it's 50% theoretical and 50% surgical training. Now, this is at the beginning, because if you don't know, if you're very good in corneal knowledge, let's say, then you can go to 80 or 90% surgery if you understand the corneal tissue well. But for new doctors who don't know the basics and they want to jump to the surgery, it's nonsense, because if anything happens, they cannot explain it. They cannot deal with it. If something happens to the tissue, they cannot predict it. So they cannot act on it, and this will doom the surgery, even if the steps were performed or executed perfectly. So 50-50 for the beginners. For the well-established, let's say, doctors who have good knowledge of the corneal tissue, then they can go to 70 or 80% learning about the procedure itself.
Yeah,
Yes,
great answer.
I totally agree with Dr. Nancy, but I add a very important tool of learning nowadays is YouTube.
Yes.
So I think the theoretical part is very important, and before making hands-on learning YouTube videos, I have already learned a lot from YouTube videos, which is a very important source of knowledge. So if I'm allowed to say 30% theoretical, 30% watching other people working, whether live or in YouTube, and 30% hands-on. This will make the whole experience.
Yeah, but if I may just comment before Dr. Mohammed Bahjat maybe answers, the YouTube is a very good tool in experienced hands, because if unexperienced hands try to take tips and tricks from everywhere, it's a mess, and they cannot just focus on what's going on. In experienced hands like yourself, on people who are performing surgery, but sometimes they just need the tweaking. There's sometimes a trick you take from the YouTube you haven't thought of before, you haven't tried, just solves the mystery of something you were hassling in. But for the beginners, trying the YouTube on patients, just this will mess things out. So let the YouTube be a tool for the specialty doctors. Maybe it's better than those who are beginners.
You are right, of course, but as you know, YouTube has both the basic techniques and as well as the advanced technique. So if anyone, for example, wants to start phacoemulsification, he can watch just the basic techniques of phacoemulsification, not to jump to the tricky situation and special tips. But you are right in your opinion. I agree with you.
Sometimes a difficult trick in experienced hand would seem very easy and straightforward. And when you want to try it, it just comes out like that's very difficult. And this is what I faced with some of the fellows, that they watch something and they want to practice it. And then I come and see what's going on. And it's a hassle. And you want to teach them to go back to basics and know this happened because you're doing 1, 2, 3. Go back and do this and this and this. And sometimes they tell me, when we look at you do the surgery or this procedure, it just looks so easy. When you want to come and do it, it just takes a long time. And this is everything about learning. It's just not only the Dmacc. Every learning needs a curve. So yeah.
Yeah, thank you. What about Dr. Mohammed, please, Professor Mohammed?
Yes, I agree that 50% theoretical and 50% hands-on. YouTube is a valuable tool, but it is not, as Dr. Nancy said, it is not for beginners. Many of our residents and fellow watch a YouTube video and want to apply this on the surgery. Usually I tell them that remember that YouTube videos are edited videos. You see the good part of the surgery. You don't see other things happening, and you don't see the post-operative. You do not know how this patient went. So it may be a very good surgery and the patient benefits from the surgery, or you may find a very good surgery and a very stormy post-operative period. So I agree that YouTube is for expert to refine your technique or to add a new technique for
Absolutely.
Yeah,
and of course, the theoretical, also the new generation is neglecting the theoretical. Yes.
Yes.
Yeah, great. Thank you very much. So what I learned from you now, that there is no available didactic instructional videos regarding these surgeries. Is that right? Available on the internet. Didactic instructionals like step-by-step and systematic. Is that right?
For myself, I have already posted a video on a step-by-step Dmacc and showing the technique, and it has narration with my voice. This was about 14 minutes video. And I have also posted some of my workshops. I always do workshops in Egypt for Dmacc. I have posted some of these workshops on the net. That's why I'm telling that gaining experience from the YouTube may help, regardless of the time of practice, whether the beginner or the experienced surgeon. But this is still, in my opinion, a very important tool. Of course, if I am experienced enough, I will be able to take what benefit me and leave what doesn't benefit me. But I think it has a role also for the beginners, yeah, more or less.
Fantastic. Thank you very much. This is what I want to reach, that Professor Tariq Qatamish has his own YouTube channel, and he is posting such wonderful videos for the audience as a reference, if you would like to watch his videos. And at the same time, he is doing like instructional course and hands-on. And I am one of the waiting list. But I don't know when the waiting list will finish. I don't know. It has been a year now.
We have a very big, Muhammad of course knows this, where they have a lot of troubles of importing corneas from outside Egypt, and especially the research corneas. Even the research corneas, we have a lot of troubles in importing the research corneas. So that's why my workshop is stopped nowadays because of this technical problem, unfortunately.
Hopefully, inshallah, you will go back again to these wonderful workshops, inshallah. Thank you very much. And of course, I would like to know whether Dr. Nancy is planning in the future to do such workshops for the Dmacc.
Actually, yes, we planned before the Corona to have, there was the conference before the COVID, to have a workshop that was canceled at the last minute, unfortunately. I hope as we go back to, I think we are going back here. Yeah, especially in the Royal Medical Services International Conference, we're planning to do like live workshops for these.
Inshallah. All the best for all of you.
Thank you very much.
At the end of this session, I would like to thank you very much, Dr. Nancy, for the wonderful lecture. And of course, I would like to thank Professor Tariq Qatamish and Professor Mohammed Goueda for being with us. And of course, the presence of the big name, Professor Osama Ibrahim, although he is silent, but his big name is always a pleasure. And of course, thank you very much for the audience for being with us. The lecture is recorded and will be uploaded by tomorrow, inshallah, to the Sinjab Academy YouTube. And have a pleasant night for all of you. Thank you very much and good night. Assalamu alaikum.
Thank you. Alaikum assalam. Bye-bye.